Well, good morning or good afternoon, depending on where you are. My name is Joy Burkhardt, and I'm the founder and executive director of 2020 Mom. We're a national nonprofit that's working to close gaps in maternal mental health care. And with us today are several guests that I'm going to introduce in just a moment. And we're here today to present a winning program in our Innovation Awards series funded by the Zoma Foundation. We're so glad to get to hear about the Virginia Moms program from several folks from the Virginia Commonwealth University today. And before we get to introductions, I wanted to remind everyone that we've got about an hour together. We'll have time for questions and answers, and we encourage you to use the GoToWebinar control panel that's here on the right-hand side of your screen. Normally it's on the right side, and it's a rectangular box. You'll see that there's a little triangle to open up a question feature, and we want to encourage all of you to use that Q&A feature. You're welcome to introduce yourselves. I see one of the 2020 Mom Ambassadors who's doing great work in her community on the line. Hi, Lola, and others, if you're on the line, you're welcome to introduce yourself. We've got about 30 of you with us live, and we have about 135 people that registered to receive the recording. So welcome to all of you as well. Before we get into the program, I just wanted to give two of our team members a chance to say hello, who do a lot of work behind the scenes with this program and webinars. And I'm going to ask that Christina Delaney first have an opportunity to introduce herself, and then Stacy on our team. Christina?
Hey, everybody. Thank you so much for being here. And I'm excited to get to showcase Virginia Moms today and all their hard work. And I'm just glad to be here and thankful for the opportunity.
Thank you, Christina. Why don't I turn it over to Stacy Porter next? Stacy?
Hi, everyone. I echo Christina's sentiments about being thrilled to be here, and thank you so much for tuning in. I just wanted to also put a little plug in for 2020 Moms Ambassador Program, as Joy just mentioned. That's our volunteer program where we are making sure that maternal mental health awareness is out in your own communities. So feel free to contact me about that or look for more information online, and enjoy the webinar today.
All right, thank you. So with that, I have the pleasure of introducing our three panelists today. We're going to start with Dr. Rigby. And Dr. Rigby, it's great to see your face on the screen again today. I know we had a chance to meet at the event at the Marseille Society of North America conference where you presented your program. Welcome back. It's good to see you again. And I'm going to go ahead and do a quick introduction. I'm going to introduce everyone, and then if you each want to add any additional detail as you jump into the program today, feel free to give any more background that you think is relevant to the award. All right, so I want to start with Dr. Rigby. Dr. Rigby is an associate professor in the maternal-fetal division at Virginia Commonwealth University in the OBGYN department. And for those that aren't familiar with that type of specialist, it's high-risk OB. So wonderful to have so many high-risk OBs partnering in the maternal mental health field. She has a lot of amazing experience, including graduating from Princeton University and elsewhere, and also has an interest in doing work around human trafficking and other important community-based programs. All right, I'm going to now introduce Janet Abraham. She is a clinical social worker with 20 years of experience in social work and health policy and administration. We love that, Janet. It's in our blood, too. We've got to talk about that more offline as well. And she's done great work practicing with high-risk patients, OB patients in the OBGYN department. She's also on the board has been on the board for Postpartum Support Virginia, which I know was instrumental and had some ties to helping raise awareness and bring about the program. So we'll be talking a little bit about that as well. Welcome, Janet. And then finally, I would like to introduce Dr. Shaw. Dr. Shaw is a board-certified psychiatrist in specializing in reproductive psychiatry. We need so many more of you, Dr. Shaw. We're so grateful for you. She has completed several a fellowship in psychosomatic medicine also at VCU, Virginia Commonwealth University, and evaluates and treats women around maternal mental health disorders, and is also actively training medical students and residents and fellows, which we need more of as well. So welcome to the three of you. Thank you, Dr. Shah. I'm going to go ahead and turn it over to Dr. Rigby to kick us off. We're going to talk a little bit about the timeline, but Dr. Rigby, I'd love for you to first tell our listeners a little bit about how you all came to be. And we usually find that there is perhaps an initial singular champion or maybe multiple champions that started this work. And I would love to learn more about who was the initial seed planter with the Virginia Moms program.
Well, I would say it began in our high-risk clinic 3 years prior to starting the program, where we were very lucky to have a series of years where we actually had a psychiatric fellow in one high-risk clinic per week for 1 year each. And Janet came to join our program around then. So it was myself and Janet that were conversing when we had a crisis when the psychiatric fellows were going away. And then we were very, very fortunate because one of the psychiatric fellows had been Dr. Shah. And so it was the three of us coming together to try and figure out, in the absence of the psychiatric fellows, could we actually create a more formal program within a high-risk clinic that would have more of a staying power and wouldn't be dependent on whether the fellows would be there that year or not. And so 1 year prior to starting the program, myself, who was the high-risk attending who had been in that clinic, as well as Janet Abraham, the social worker, as well as Dr. Shah, the former fellow, got together and said, can we formalize this? Can we get buy-in from psych and from OB to make this more of a permanent feature as opposed to one that was changeable year to year? And so then we had to have multiple meetings. We thought, oh, this is going to be a piece of cake. And let me assure you, it was not a piece of cake. No. We had to get buy-in from the OB chief and the psych chief and the person who ran the clinic, and then the all-important budget people. And they were very hesitant. And so they let us do a trial run of 1 year, and then we did a reassessment. And they let us continue. And then we've also more recently had the very good addition of postpartum support groups, where we have brought in even many more people into the process of helping us strengthen the postpartum moms program.
Okay, great. Well, it's always helpful to start with the champions and how things came to be. I think it's a nice segue into your timeline, and I'm not sure if the three of you want to take turns. You all can decide who can answer these questions, but it is helpful, and you've teed this up nicely, that these things don't happen overnight. Before we get into the timeline, though, please why don't you start with just a general overview of the program for those that haven't heard about it or had a chance to read about the program on our website yet. Tell us a little bit about this collaborative care model, where it's based, at the university clinic, etc., and then we'll jump into the timeline.
Basically, the beauty of this program is that it's an integrative discipline where the three of us, maternal-fetal medicine, social work, psychiatry, collaborate together to support women in this critical postpartum time frame. And so basically we're able to identify women that are at risk on a variety of levels, either before they come to our practice or in the context of us seeing them in their clinical prenatal care. And we are able to triage them for appropriateness, look at whether or not they are perhaps at a higher risk level for developing postpartum depression, as well as considerations for things such as, do they need acute medication management? Do they need hands-on care because they've had previous psychotic episodes related to previous pregnancy?
and then we're able to establish care. In most cases, it's after they deliver with Dr. Shaw, but in some cases, based on the acuity and based on the need, they can also be started with psychiatry care assessment and otherwise during the context of their prenatal care. So again, it's very individualized and it's on a case-by-case basis, but the ideal is interdisciplinary collaborative care to not only utilize our expertise, but to follow them through the pregnancy and throughout that fourth trimester.
That's great. Before we get into some questions about I'm sure there are a few questions. I've got a couple even from that introduction, which was helpful. Tell us a little bit more about your community and the clinic in the university setting. And, I think many people know that there are clinics that serve, when there's a medical school, there's clinics that serve the community, not just the students on campus. Can you just give us a feel for your community surrounding Virginia Commonwealth University and where you're based?
Sure. We are an urban academic institution, and we serve as a safety net for the Commonwealth of Virginia. And so our community includes a variety of various socioeconomic mixes. And in our clinic, we're available to any or all of those folks that comprise our community. Many times we also serve, because we're an institution of excellence, we also serve folks in the rural community that will come to seek the services of maternal-fetal medicine, which Dr. Rigby represents, and we really think it's important to serve those continuum and complexities of all variety of socioeconomic folks. So we have a real interdisciplinary and a real melting pot of folks that come to us from the community. Yes, we're an urban setting, but we also serve folks in the rural community as well.
Okay, so tell us a little bit more about that, the community. I have two follow-up questions that folks might also be interested in. When you mention wanting to serve everyone, can you talk to us a little bit about insurance? Did you serve the Medicaid population in Virginia and maybe privately insured women as well? And then remind us how it works if you are in an urban setting and also serve rural women in rural settings too. Does that mean that there's more than one clinic that you're working through?
Well, in our OB practice, we have a variety of different clinics. However, we also are insurance blind. So essentially, we do serve Medicaid population, and we also have various relationships with health department institutions and otherwise. So we provide funding and care for them in exchange for those women delivering at our institution. But we have a private pay Medicaid mix. I think percentage-wise, we do quite a bit of Medicaid folks. We also have just most recently taken on as the lead player in this prenatal care for the folks that are in the health districts. So we now, at least in the city of Richmond, also provide solely primary prenatal care for the women that catch all. So we now do community practice care for Medicaid folks in the Richmond community.
We also partner with South Hill, a community memorial hospital, which is a hospital in a more rural area, about an hour and a half, 2 hours away. And we provide remote ultrasound reads to that hospital, and we have weekly conferences with them. And so we will also get patients from that rural catchment area, either portions of their prenatal care or for delivery, depending on what's appropriate. So we have a special relationship with that hospital, mainly via telemedicine, and then the patients coming here as needed.
Great. That's really interesting. Thanks for sharing that information. And just reminder for folks, if you do have questions at any point, you're welcome to add them to the question feature and go to the GoToWebinar control panel. Excellent. Okay, so I think we have a little bit of a sense for the community you serve and the partners in your program, and it's really interesting to hear that you're partnering with a rural practice as well to deliver care, and really important from that perspective. It's very helpful. Why don't we go ahead and walk through the timeline first, and we'll go ahead and turn it back to any of you that would like to walk us through the timeline.
Okay. So as we had touched on previously, 3 years prior to starting the clinic, we did have the presence of psychiatry in the high-risk clinics. It was a variable timing, but we did have psychiatric fellows who would more or less come to one of the high-risk clinics, mainly for a year at a time. But then the pipeline of those fellows dried up, and so we had no one coming to deliver our psychiatric care, and we panicked. And so that's when we got together with Dr. Shaw, who was one of those former fellows, and tried to see if we could put into place a more formal clinic and follow up in collaboration with a maternal-fetal medicine person who would have been me, as well as Janet from the social work side and Dr. Shaw. And that's when we started our odyssey of trying to get more formal support for the clinic that became Virginia Moms. And
can I piggyback one thing that I would add, which Dr. Rigby did touch on? I think it truly was a leap of faith for the health system to really trust us and on our instinct that this was clearly a need. And I think the key is that we were able to convey to them the need. And the key also was that we marketed it and we conveyed to them that we just wanted to try it. We just wanted this to be a pilot project. And we were certainly able, willing, and very much astute in looking at that process after a year to see whether or not we were making an impact. So I think that was a piece of it that was helpful for us as champions of a program initiative to just say, let us try it, let us pilot it, let us see if people come, let us see if we make any differences.
Yeah, that's a really great point, is that sometimes starting with the pilot to allow those that might be skeptical, right?
Yes.
To see what the impact might be is a good way to start versus launching a full-blown program. That's really helpful. Very good. Excellent. So any questions from folks on the line using that question feature about the timeline thus far? All right. Anything else that we should know about the timeline here before we move on to the next slide?
I just think that you need to be very persistent. You know, if we had taken no for an answer, we would not be here right now. Yeah. So we knew it was important, but it took a little bit of convincing and multiple meetings to convince other people that it was important.
Very good. Yep, persistence would be the key takeaway, it seems, for scaling or implementing a program like this. Very good. Very helpful. I also, you touch on support groups. You touched on it earlier, but also just want to have you spend a little more time on the use of support groups. I know you launched in 2017, the program, and then I think you had added support groups perhaps more recently in 2019. Is my recollection correct? And talk a little bit about how you saw the need and why you saw the need, and then who are you partnering with to provide that support group work?
Sure. We started the support groups, I believe it was last year, 2018. We looked at the model that the Postpartum Support Virginia framework provided, and we actually collaborated with them and had them come down here and do some training for some of the folks that were going to be some of the stakeholders in facilitating those efforts. And so we thought that the value of training, obviously we weren't going to put something in place without having the facilitators appropriately trained, but we really liked that model, and we had used that model as an opportunity to evaluate how this support group was doing in other parts of the state, and we chose to also be a part of that model and coming together as it also being a continuum of care. Dr. Shaw will often make that as a suggestive treatment piece for her patients as well. And basically, we also have a work group that is comprised of the facilitators, of Dr. Shaw, of Dr. Rigby, myself, and we have the opportunity to look at timelines and when we're going to have the groups. And we've also incorporated recently the work efforts of our VCU Health Marketing Department. They also are large players in this effort and also supported financially. So we have had a great deal of participation with that and a lot of support from patients. And I'd say we've probably touched about 100 patients since the time frame of when we started. So we look at that as something that's a nice piece to add on for an additional piece of support for these women after they've had their babies.
And I would say what's wonderful about the postpartum support group aspect of it is that the people who help us with that, we have pediatric MDs, we have pediatric social work, we have OBGYN nurses, we have OB inpatient social work, we've got translators, we've got nursing students. I mean, it's really reaching out to the medical community and having them come back to kind of envelop these women in the support. And we have people who really give a lot of their time in helping us with that. I think it's also helped us reach out to other people in the medical community who are very interested in helping. And yeah.
They're essentially volunteering their time because it's not like they're getting paid for doing this. In the context of supporting the groups, there are students, nursing students, that will take care of the children while the new mothers are participating in groups. Why these groups are very effective is also because if there's a huge wait time for appointments, the patients then attend these groups while they're waiting for the appointments so they can get all the help they need.
Oh, great. That's a really helpful point, both childcare and that there's an immediate service that's available while patients are waiting. And I think that may have been you, Dr. Shaw, and I assume that patients may be waiting for psychiatric support from you. Is that appropriate assumption?
Yes, so I primarily do medication management in the clinic. For psychotherapy sessions, typically I will refer patients out to the psychiatry residents. As Janet pointed out, that we serve a pretty significant Medicaid population, and so they don't have the money to be able to afford psychotherapy sessions. So with their permission, I refer them out to residents for psychotherapy sessions. These residents are supervised by faculty from VCU. So that has been an additional source of support. But as far as I'm concerned, I primarily do medication management.
Yes, great. We're following. Yep, that's helpful. Yep. Can we walk through one more example of how your process works, and then we'll move on to the next slide. I wanted to talk about it. I love that you all are including pregnancy in this time of perinatal treatment for maternal mental illness. Often we are still seeing great programs pop up, but still focused only on the postpartum period. So if you could walk us through, Dr. Rigby, a patient that comes in, with or without a prior history, and pregnant again into one of the clinics, what happens? Who does the screening? What kind of words are used to talk to mom about these disorders? When does Janet get plugged in? Who develops the treatment plan with mom? If you could just walk us through, with your visual, like give us a visual with your words, that would be really helpful.
So we have 4 high-risk clinics a week, and when we were first putting this new plan into development, it was originally in the Thursday high-risk clinic, and it was going to be needed to switch to the Tuesday high-risk clinic. And I was talking with one of my MFM colleagues about that, and he was very resistant to the idea until I explained to him, I'm moving the psychiatric patients with me, and then he was fine to switch it to Tuesday high-risk clinic. So the Tuesday high-risk clinic is known as the place where if, say, a resident is discharging someone or identify someone who is at high risk for psychiatric sequelae, that's the clinic that they come to. That's the one that, if they have other high risk problems, that's fine. But if a psychiatric component is important, then they know that's the high risk clinic to come to. And Janet is really the person who we use to help triage our patients. There's many a patient that's being checked out to me in the high-risk clinic, and I'm like, okay, so when is she seeing Janet? Have we told Janet? And Janet and I and Dr. Shaw will go through the list to try and prioritize who needs to be seen by who when. If we identify a patient that's not in the Tuesday high-risk clinic and we need either Dr. Shaw or Janet to weigh in on her ongoing care, we will send them notes or we can call them. And so we try to flag patients specifically to see Janet if we think that that's going to be one of their primary needs. And then Janet is very good about taking the initial interview of the patient to try and determine, is it just a minor adjustments of their medications? Is there an ongoing person that they're seeing that is taking care of their psychiatric needs? Do we need to consult with Dr. Shaw? And there are times when Dr. Shaw gets a panicked phone call from us, saying, we have a patient right now, can you add her onto the schedule today? And so the residents know and the attendings know that if they have a patient that has a particular problem, they can call Janet to try and get her triaged more quickly. And as a general rule of thumb, anyone with significant psychiatric illnesses is sent to the Tuesday high-risk afternoon clinic. And then Dr. Shaw is running her postpartum clinic there at the same time. We have a very close working relationship.
I'd like to just piggyback on that. Another thing that I use as my touch point is we have strategic times that we've developed training EPDS tool, and I'll use that as a talking point and as sort of benchmark to determine where a patient is, and then it gives me the opportunity to rule in or rule out self-harm. And obviously, once that piece is tucked in, I can make a determination as to whether need is specific to yesterday or specific to we have a little time to plug them in. So that's a very important, critical piece of what I use diagnostically to determine and to get an idea of where the patient's at.
That's helpful, and I don't think you hit on this yet. Is there is that same screening done routinely for all patients
Yes.
when they come to clinic when they're pregnant, or is it just after?
And I would say that was one of the great things that gave us momentum when we were trying to sell the clinic, was the idea that the depression screening should not just occur 6 weeks postpartum. But so in our clinics, when we're starting to get the momentum for this clinic going, we shared with them that ideally speaking, it should be done at the first prenatal visit and at a minimum the 28-week visit, as well as before they left the hospital, and then at the 6-week visit. And our pediatric colleagues have been very good about incorporating it into their clinics. And it was when the hospital administration all of a sudden discovered that we were going to be getting all of this extra information on the psychiatric health of our patients. It helped us to explain to them why it was to have a special place for these patients who we were newly identifying to go to.
Great, that's helpful. And I think sometimes people forget that the percentage of new onset and pregnancy is nearly as high for maternal depression as in pregnancy as in the postpartum period. And we're seeing more and more childbearing age women with pre-existing anxiety and depression, particularly in low-income populations. So I just applaud you for the work that you're doing and focusing on that pregnancy period as well. Great. Well, we're going to go ahead and move slides here. And we talked a little bit about this already. I probably should have flipped to this slide, but I'm going to turn it back over to you and talk to us a little bit more about anything on this slide that you want to highlight. And then we'd also love for you to talk a little bit about treatment plan development and how that works with mom. And we know that some mothers often are afraid to consider medication, and what does that look like in your model? anything else you want to share on this slide would be helpful.
Well, I think that's where Dr. Shah has been so helpful because, there are times when we are confronted with a plethora of medications that maybe the patient is still on, maybe she's stopped half of them, maybe she stopped all of them, and it can be very tricky for us as OB providers to really figure out exactly what we need to do moving forward. And Dr. Shah Janet can help start that triage process, and then Dr. Shah can be very helpful in determining what types of medications or follow-up the patient will need. Dr. Shah?
From this slide, what I would pinpoint is that typically the time frame to see a psychiatrist is between 6 to 7 months for an initial evaluation. But because we have this clinic here, the time frame is reduced significantly, and we're able to, with Janet's help, of course, triage them in within 2 weeks if they really need to be seen in that time frame. So I would say that with this clinic, we've been able to reduce the time required to see a psychiatrist for an initial evaluation. What I would also add is, to your point, there are a lot of patients who are scared of being on medications if they're pregnant. My role is to provide as much information as I can in terms of standard of care, in terms of how bad their depression or anxiety has been in the past, how bad it is likely going to be without medication management. Sometimes having their significant others or spouses or family members with them is helpful, where they listen, you need to be on your medicine because if you're not, you get really, really depressed. I know that one of the big factors for postpartum depression is untreated or undertreated depression during pregnancy. So my role is to explain the importance of treatment, whether it is psychotherapy or med management. And at the end of the day, the final decision rests with the patient. But yes, there are quite a few patients who prefer not to be on medications. We see a lot of patients who see providers in the community and who advise them to stop that they're pregnant. And that is usually not a good strategy, especially because by the time I see them, they're already going through severe depression and anxiety. So it's education about medication management, education about side effect profile. That's an important part of what we do in the clinic.
And the other thing that I think has been very helpful is, since we've kind of become known as having some degree of expertise in this, we've given grand rounds for OBGYN, we've given community talks regarding this, and I think anytime you can get the facts laid out, in terms of the pros and cons of medication use in pregnancy, I think both to OB providers and to the community, it is a big help.
Absolutely. Yep. You have a full plate with managing sort of that prevention piece and educating the community providers around medication safety, and not to remove a mother before consulting with someone like you, Dr. Shah, on top of everything else that you're doing here. That's great. Anyone else, the three of you, want to bring up anything on this slide?
And this is Janet. The other thing that I think I would just also like to highlight is that in doing the grand rounds that incorporate the audience obviously being also attended as the residents, it's really just been it's been incredible to see the confidence that is developed in the OB residents, because they've been given the education, they've been given the knowledge of how to guide the patient who's depressed. With the expertise that we've gathered from Dr. Shah and her experience and her education of the residents, it's just been wonderful to watch these residents grow with their degree of confidence and care.
And it's also been a two-way street, because I'm also known as the go-to OB for any OB psych topic that's talked at the psych lunch seminar series. So I'm generally over in their neck of the woods about twice a year to help talk to them.
And because
That's
of
great.
we are also able to generate interest among medical students who normally would not get a chance to rotate in a clinic like this, but because they hear about it and want to be a part of this clinic, right from the level of the third year of medical school, they're able to see pregnant and postpartum women with mental health issues and understand the impact that psychiatric disorders have during pregnancy and postpartum. So I think education is a big part of this.
Absolutely. And let me ask you something that's not quite a Virginia mom's question, but since both of you have hit on the importance of educating OBs in particular, have you seen that the curriculum that's being covered during coursework and other types of training for students is covering adequately from your perspective, the range of maternal mental health disorders, the importance of treatment, all of those things? Is that starting to change from your perspective?
Well, I'm so glad you brought that up, because that's actually one of our next steps is we are really hoping to develop an education using simulation involving both the OB and the peds and the psychiatric residents, and maybe getting them together with a simulated patient once a year to do a case all together. So that's one of our next hopes is we can use our resources to develop learning that would involve all three of those levels of residents to help put together the pieces of the patient in that setting as well.
That's great. Please keep all of us abreast of that work. We'd love to lift that up as a model as well to other medical schools. So thank you for that work. Before we move on to the next slide that really talks about, I think, some of the numbers from your program, I also just wanted to share for those listening online today, joining us live, we would like to point out that Postpartum Support Virginia, the program that they created, that Virginia Moms is using for support groups, is available through Postpartum Support Virginia. That's rebranded as Help and Hope. And we, 2020 Mom, has partnered with them to bring a training to the community on one occasion. And if folks are interested in learning more about that model, one of the things that we really like about it was touched on briefly, but it's a model that uses both a peer and a clinician. So peer-led and clinician-supported is the term that we've heard them use before, but a really nice partnership of both peer and clinician support. So if you have more interest in that program, feel free to email any of us. You'll see our emails up here on the end of the slide. We're going to go ahead and move on to the next slide, which is the numbers slide, how Virginia Moms is actually making a difference. So I'll turn it back to the three of you.
Basically, what we've had the opportunity to look at is how can we make a difference, outcome-driven, reducing the number of inpatient psychiatric hospitalizations, and in doing so, the numbers thus far that we've seen is about 120 patients that are triaged by me, who then are utilized or are looked at for purposes of screening. And we look at things like their need for service, including but not limited to elevated EPDS scores. We look at, I look at previous postpartum depression or hospitalizations, actual inpatient hospitalizations. Many times our patients will come to us and they will not have continuum of care with their psychiatrist in the community. They look to us as providing expertise, and we have to establish generalized care in a psychiatry clinic, which is our clinic. And in doing so, we have seen about 100 patients that have been referred for detailed psychiatric assessment and intervention. And then, as we touched upon before, the support group also have touched about 41 patients thus far. In speaking to the support group initiative, we're also going to be relaunching a support group that specifically focuses on our Hispanic community, and we have collaborated with a church community in the south side part of our geographic area, a Catholic church called St. Augustine, and they are going to be working with us to welcome Hispanic patients into a support group setting located in the church, trained with our trained facilitators, and that is going to relaunch and begin in January. That effort will be slow in that we'll do it once a month so we can get an established base of interested folks that are coming and trustful and being a part of this treatment initiative, and our first one is going to be launched, I believe it's the third week in January. So that kind of gives you a bit of an overview of the number of folks that we've touched. Dr. Shaw may be able to speak to, how do we measure outcome? How do we know we've made a difference?
So as far as we know of the patients that we've seen so far, we haven't had any inpatient hospitalizations, to the best of our knowledge. Typically, we use hospitalizations as the reference point to get an understanding of, are we doing a good job or not? In general, follow-up has been as good as we had expected it to be. The dropout rates are not very bad, so patients do come to clinic, come for follow-up appointments. Not all of them take their medications, but that can be generalized to the rest of the population as well. So overall, as far as we know, to the best of our ability, we do not know of any hospitalizations for the patients that we've seen in the clinic and that we have sent to the postpartum support group.
And Dr. Shaw will see a part of our guideline is Dr. Shaw will follow these patients up to a year postpartum, and then she has the opportunity to collaborate with the outpatient psychiatry practice, and she can elect to continue to follow them or have a colleague follow them if the need is necessary.
So if they have a psychiatrist in the community that they can go back to, then after the end of the year, that's what we do. If they don't have a psychiatrist and they need to be seen for follow-up, then I will see them, not in the high-risk OB clinic, but in my other clinic at VCU. Or if the need is different, if they need more case management services, then we refer them to a community program that can be more beneficial for them.
And can I piggyback on that? Joy, when I look at the overarching term, how do we make a difference? Can I give a specific example of a patient in clinic that we truly, I believe, were able to make a difference that might convey to your listeners kind of grassroots how we're really doing this? We had a patient in our setting who we were following who had a high incidence of panic attacks. And it was a Tuesday, fortunately, and she truly was decompensating in the context of her clinical intervention, of her prenatal care.
In the midst of high-risk
clinic. Dr. Rigby, I conferred with Dr. Rigby, and we both agreed that in the context of a full load that Dr. Shaw had, we still felt that it would be really important to see if we might be able to make provision at live time for this patient, and Dr. Shaw was able to get it stabilized to a point where we did not have to initiate an inpatient hospitalization.
And because it would have been so much more traumatic for the patient to have been shunted to the emergency room.
Yes. Well, and again, sort of that umbrella of anxiety disorders seems to be cropping up, and we're talking about these disorders much more often. And so really good to hear that you were able to support this woman with a panic attack and get her to a place where she was stable and avoided the ER. Really good stuff. Great. Well, we're going to just see if anyone has questions. I think a couple have popped in. All right. So do you think, I'm going to ask this question just slightly differently. It really does seem like this model that you've created could be lifted up and utilized in similar university settings where there are psychiatric fellows and OB residents and others readily available and interested in learning and providing time. The nursing student example was fantastic. Someone's asking, if you were to be able to wanting to create a program like this outside of a university setting, how would you start? What would you do? And what would you say would be possible without a university, or the medical school and nursing school students supporting a program?
Well, I think you need to, as you mentioned in your first slide, champions. So, I think if you could get a community OB person and a community psych person in conjunction with social work interested, I think it's perfectly possible to try and carve out an afternoon in one of those three spots to try and these ladies. I think you have to start with some champions, though, that understand how important it is and are willing to put in the time and effort to try and make it happen.
Yeah, that's great. And I would add, it's Joy, that these programs we're seeing start to get cropped up in large health systems, so hospital health systems, where there are multiple clinics and hospitals in a system. That's a place where we can scale these types of programs. And if you're in a community-based OBGYN, for example, and interested in doing this work with a nonprofit, others, we've started to see, based off of community coalitions forming to address maternal mental health, with a backbone nonprofit usually, which can be a hospital even, that some of this work is starting to happen through those kind of coalition settings. So it's I would say it's difficult in part, but it's possible. So feel free to email any of us if you've got questions about how to get started with a program like this around collaborative care and different stakeholders, clinical stakeholders becoming involved in setting up a program. Excellent. Well, why don't we go ahead and move on to the next slide? And thank you for that question. This is a good segue again with who are your partners, community-based partners. We've heard about Postpartum Support Virginia. Tell us about who else you're working with.
I love that you, kind of going back a slide, I love that you highlighted the important work that coalitions and together folks can do to make a difference. And we actually have formed a Greater Richmond Maternal Mental Health Coalition in Richmond that you can flip to the next slide now. Yes, that collaborates with a lot of our community stakeholders, and that is comprised of women and men in the maternal mental health community that are interested in these efforts. It has representatives from Postpartum Support Virginia, from Urban Baby Beginnings, which is a very dynamic community organization serving women, primarily the Medicaid population. Nurture, which is another organization in our community that educates around breastfeeding and around maternal mental health issues. And this is an effort, the Mental Health Coalition is an effort that also tracks legislation with respect to what's going on in Virginia and ways we can highlight that. And this is something that we've just actually reinvigorated it and relaunched it. We had our first meeting in December of this group. So we are well on our way, we hope, to connecting the dots with folks of like-minded issues concerned with these overarching issues of maternal mental health.
Excellent. Well, I will share again. It's Joy, 2020 Mom, with some funding again from the Zoma Foundation, created a community action toolkit for coalitions to utilize, just like the Richmond Coalition for Maternal Mental Health. For those of you that have not yet started a community coalition around maternal mental health and want to bring people together, we have a great roadmap for doing that. And we're welcome you to find that on our website. And again, we'll share it with those that are interested. I'm going to move on to the closing slide. Q&A, and let me just leave it here for just a moment and see if anyone else has questions that they want to ask. And while we're waiting to see if anyone has any other questions they want to raise, why don't I turn it back to each of the three of you, if you don't mind, and we'll start with Dr. Rigby, and then move to Janet, and then Dr. Shaw. If you were to leave us with 2 or 3 parting words or a thought, what would that be?
Well, I want to thank you guys because sometimes it feels like we're working in the wilderness. And I must say that when we were told of the possibility to apply for your Innovation Award, it really gave us the energy to take a look at our program and to see how we could present it. And it has really uplifted our program in the eyes of the medical center. So I really just want to give a heartfelt thank you to you guys for all of the hard work that you do, because it has really helped us move our objectives along. So thank you so very much for giving us this forum.
Well, thank you for those kind words. That means a lot to us, and we will take that to heart and make sure the funder knows that you really appreciated the opportunity as well. Thank you, Dr. Rigby, for those thoughts. Janet, we'll turn it over to you.
Sure. I think three words for me come to mind that resonate this whole journey, and that is collaboration, communication, and persistence. Because without those 3 things, we would have walked away like a dog with tail between their legs and just said, okay. But we really, really, I know I personally wouldn't take no for an answer. And I leaned on these 2 ladies as well. And together as a team, we just really kind of mustered along and hope we're at a point that's real different than 2 years ago. So, again, thank you for the opportunity to raise awareness with your stakeholders. But those would be the 3 words that would resonate with me.
Well,
that's great.
It sounds like Dr. Rigby and Janet have said it all. So thank you, guys. A special shout out to the people who run our support groups for free. Thank you to the Departments of Psychiatry and OB who have made this possible. A huge thank you to VCU, and a huge thank you to you for organizing this. Thank you.
Fantastic. Well, we did give folks, as we were requesting your final thoughts, some time to ask questions. We had a few more come in here. Let's make sure that we have a chance to ask them quickly. And Stacy, I may need your help on a couple of these. Sometimes they're a little bit difficult to read. Okay, let me ask. So this one's interesting. Has receptivity and sort of the issue of stigma been, have you seen it change over the last couple of years since launching your program for both clients and it says volunteers? I would add providers, and I think the answer would be yes. But anything you want to share about that S word, stigma, and what you're seeing change?
I think that's one of the beauties of doing the EDS scoring so many times during the pregnancy, that it becomes a routine thing, and that, the nurses know, oh, Dr. Rigby, look at this score, and, we really need to pay attention. And so making that more of a routine part of the care cycle, I think has really gone a long way to, just like we do your 28-week glucose, we do your 28-week Edinburgh Depression Scale. So I think just making it more routine in terms of checking in on maternal mental health has gone a long way toward breaking down some of this that can be associated with it.
That's great. Yeah, absolutely. That's what they say, that screening is education, right, for everyone. Excellent. That's a great point. Someone wanted to point out that there's a new national curriculum for reproductive psychiatrists. We will make sure that we send it out. Stacy, let's do that with the autoresponder email that goes out with the recording for today's session. Include a link to that site about that new national curriculum that's available.
Yes.
It's web-based.
Yeah, I had an opportunity to go to one of the breakout sessions there, and it's very, very thorough and very, very exciting. I think the amount of work that has gone into that is very, very impressive. So I encourage everyone to take a look.
That's right. And we've actually heard that there's an interest in having every psychiatrist become familiar with these segments and go through this training, that it doesn't need to be a subspecialty. There's some controversy perhaps about that, but that every psychiatrist should have this baseline knowledge and should be going through this training. Well, that's great. Stacy, I can't see any other questions. I think we've covered them all. If for some reason you do have a question, we couldn't get to it, why don't you go ahead and email us? I'm going to go ahead and put up our closing slide here. And my email is joy, Joy, at 2020mom.org, joy at 2020mom.org. We have 2 more upcoming webinars in this series of Innovation Award winners and honorable mentions that we want to invite you to register for. You can see the dates here up on our website. We did make a quick change to the Better Postpartum webinar. That one will be happening in January rather than December, and we encourage all of you to join us and register even if you can't make the session live to get the recording. Congratulations again, Virginia moms, and to the whole staff at VCU for making this program possible, and thank you to the 3 of you for your tenacity and spirit and willingness to do what is necessary to serve moms in need. We so appreciate it, and congratulations again.
Thank you so very much.
Thank you all. Take care.
Take
Bye-bye.
care. Bye.